right, we'll go ahead and get started. So hello, everyone. My name is Amanda Pyle. I am a colleague of Rob Horton at American Heart Association. I'm stepping in for him while he is out on paternity leave. He should be back at the end of the month. I am going to go over a little bit of housekeeping. So if you could just please remain muted until the end of the presentations, we will then open it up for discussions and questions. But if you have something and you don't want to forget it, feel free to put it into the chat either to everyone or directly to myself, and we can have that addressed at the end of the presentation. And then I am also, just as an American Heart Association individual, I want to make everyone aware that beginning in December, AHA is going to be holding several lunch and learns with the Joint Commission to review acute heart attack ready and primary heart attack center certifications. We'll be offering one-on-one consultation time to address any questions you have about if your hospital qualifies. So please be on the lookout for those emails that I will be sending out. And with that, I now turn over to the co-chair of VHAC, Dr. Peter O'Brien.
Great, thanks so much, Amanda, and thank you to all of our participants for calling in, for participating in what is our second virtual state meeting. I think you'll find today's program to be very interesting, very relevant to what a lot of our STEMI stakeholders are dealing with. We have two fantastic speakers lined up. Our first talk today will be on changes to the chest pain MI registry that will have definite implications for our quality improvement efforts. And then cardiac arrest. You know, when do you take a patient to the cardiac cath lab in terms of survival, and when is that appropriate, and when is that potentially not the best use of our resources? Next slide, please. I have no relevant financial or other disclosures. Next slide. So I think a lot of the people on the call have been with us for a while and are pretty familiar with what we do and who we are. But for those who are new, I do want to just say a word about the Virginia Heart Attack Coalition. We are a voluntary statewide coalition of stakeholders with a mission to work collaboratively to improve the systems of care for the early recognition and treatment of all Virginia residents suffering from heart attacks. We are now in our 12th year, and we are very, very grateful for all of you that have worked with us and proud of what we've accomplished. But of course, there's a lot more work to be done. We would love to be seeing everybody in person, and we look forward to the day when we can all get back together again for our state meeting. But for now, again, very, very appreciative that you've taken time out today. We'll do our best to make today's program as relevant and as interesting as we can. Next slide. And thank you to those who participated in our first virtual state meeting. This was back in July. Our topic centered on STEMI in the COVID era. I think this was a great event. We certainly got a lot of positive feedback. We are on our second virtual state meeting today and already planning our next one, and we'll let you know more about that in the future, so stay tuned. Next slide, please. I do want to take a couple of minutes to give you a little bit of an update on what's happened since we spoke in July. A couple of very exciting developments for VHAC. As you may remember from our discussion before, we have been working now for several years to get back to a unified STEMI registry. When the Action Registry went away, we lost kind of a unified tool to measure our progress. We have two great registries out there, Get With The Guidelines and Chest Pain MI. But in order to bring all of that data together, to kind of bring the apples and oranges together again, to make meaningful comparisons, we were really looking for something that would unify these data sets. So the Virginia Heart Attack Coalition partnered with VCSQI and have been working with that organization, with ARMIS, to try to make this a reality. I'm very excited to say that 16 PCI centers currently have the data use agreements in hand that are expanding what we're able to collect. So I won't get too far down in the weeds on all of this, but we are going to collect data points including FMC to balloon, pre-hospital EKG, transfer times, door in, door out times. And so again, those we've already gotten data use agreements out, and we're hoping, I think, by probably the first half of 2021 to begin to be able to show some of that data blinded, of course, at first, but be able to show that comparative data. And the other reason I like to bring this up on this call is because a lot of the folks on these calls are typically data abstractors, STEMI champions, nurses, EMTs, all the rest, all of our teams. When you see this, you are all really the opinion makers, the thought leaders at your hospital. So sometimes it takes a little bit of encouragement or even a little bit of administrative arm twisting to kind of get these agreements in and to get to begin to cultivate that involvement. And we really all need you to help us make this successful. Next slide, please. The other development that I want to tell you about that we're very excited to see is the cardiogenic shock initiative. Dr. Tarani approached us recently about this, and one of our speakers, Dr. Truesdell, is also actively involved with this, although he's speaking on a different topic today. And their vision was to develop a regionalized system of shock care. This will start with a survey that is in kind of the final stages of being edited, that'll be sent out to the state. So again, putting the bug in all of your ears, because when you see this come, it's something definitely we want to get done and we need your help with. But the survey will collect institutional level data on a variety of things, just to basically get a sense of what practices are across Virginia in terms of, what mechanical support device do you use? Impella, tandem heart, balloon pump, or nothing? Do all of your shock patients get a PA catheter? Things like that to begin to put together a picture of how shock is cared for in the state of Virginia. They also want to start quarterly shock clubs, virtually, of course, I would imagine at first, but basically kind of like a virtual cath conference, looking specifically at shock patients. Ultimately, this would progress on to a statewide system of shock care, which I think would be absolutely phenomenal. The reason that Dr. Tarani and his partners in Northern Virginia approached us is because, again, we are lucky to have many of you on our team already, and I feel like launching something like this would be much easier, or would be much more feasible using the networks that we have already in the relationship. So very, very excited about that. Next slide, please. I also want to put in a quick pitch for a meeting that's actually this weekend, which is the Mid-Atlantic Capital Cardiology Symposium. This is really the kind of group state meetings of the various chapters of the Mid-Atlantic states. And I think there was a program on Saturday afternoon for fellows in training, and then there's a full program the next day on a Sunday. And this is a great, great meeting. I had gone to this in person for a number of years, but I think they're going to be able to bring you some of that same content virtually. So mark your calendars for this weekend, and there's probably information that you can get from their website. So next slide, please. If you haven't already, please join, like, and follow us. Go to our website. You can sign up for updates. You can sign up for notices about other meetings related to VHAC. Plus, there's a lot of great content on the website itself. Part of it is under construction. The other thing I should mention that we've been very active with over the past several months is we're trying to make that website really a go-to place or a clearinghouse for EMS education. Quick, handy links to the guidelines, things like that. So again, check that out. Like us on Facebook, follow us on Twitter, and we would be much appreciative of that. Next slide, please. And I think that's it. So without further delay, I'm excited to introduce our first speaker today, Dr. Greg Dehmer from Carilion, Virginia Tech Medical School. Dr. Dehmer, as many of you know, is a very, very prominent and well-respected interventionalist, and I could probably spend about 20 minutes going over all that he's done. But he is currently the medical director of Quality and Cardiovascular Outcomes. He served as president of the Society of Cardiac Angiography and Intervention, was on multiple guideline writing committees. So he is really an expert in what he is about to talk to you about, and that is changes to the chest pain MI registry. So Dr. Dehmer, thank you again, and we're all ears.
Well, thank you, Peter. We're about to find out if I'm an expert at sharing my screen here. We had a practice run a little while ago, and we're going to see if I can do it again. Maybe not. Amanda, I may need your help.
We see your screen. We just need you to go into the PowerPoint presentation mode.
You got
Perfect.
it now?
Yep.
Terrific. Well, again, thank you for that very kind introduction, Peter. So, being a medical director of quality and outcomes is kind of what you evolved to after 40 years in the cath lab, and you need a break after a while. So I'm glad to talk with you about two important changes in the metrics that are in the cath or in the chest pain MI registry. So I have no financial disclosures. Some of my other disclosures kind of reflect my longstanding involvement with NCDR. I was on the management board for about 9 years, which is really longer than you're supposed to be, and have continued on with some relationship with the NCDR. This slide is something that our good folks at Carillion want us to show. It's in case any patient information sneaks into a talk that you're not supposed to record it, but we're not going to do that today, so don't worry about it. So what are these changes? Well, for all the data abstractors on the conference call today, you're probably familiar with this, but I'm mainly addressing this now to the physicians that are on the call because this is an important change, some of which you know about, some of which you probably don't know about. And we're going to kind of go over these. This was posted on the NCDR website in August the 12th to be exact. And it's changes to two metrics, number 37 and number 56. And in a nutshell, it's patients that have a long transport time will be dropped from the calculation of these two metrics, or in other words, removed from the denominator. And they're the first medical contact to device time, which is metric 37, or time to primary PCI among transferred patients. So for those that aren't familiar with this, I think most of us, if you have access, and you should have access when you go to the NCDR site, the thing you're immediately interested in is the dashboard, which contains your results. But there's really a wealth of additional data. If you go to resources and then under resources, you go to documents, this page will open. It's a documents homepage, and there's just a wealth of information there that's meant to help you understand a lot about this particular registry. If you scroll down on this, you get to this executive summary measures and metrics companion guide, which really helps you understand exactly what these metrics are looking at and measuring. So for metric number 37, which is first medical contact to device time, if you open this, what you see up at the top is a description of the metric. And basically, I'm not going to read these to you. You can kind of read them as we move through this, but this collects information on those who undergo primary PCI and have a first medical contact to device time of less than or equal to 90 minutes. Underneath that is what's in the numerator and denominator. So it's the first medical contact, or if they don't call EMS and they just arrive at your facility straight up, it's when they arrived, or for those patients that arrive with chest pain but are not initially having evidence of myocardial infarction, but then subsequently during their ED visit they have more pain, they elevate their ST segments, that then becomes the time that you start the clock. So that's the time the first ECG is positive to device time. The denominator is patients with pre-admit STEMI. Now, I must admit, the first time I saw that, I was kind of wondering what on earth is a pre-admit STEMI. It's probably easier to discuss what's a post-admit STEMI. Those are the in-house STEMIs, a term I think that we're more familiar with. They use the term pre-admit STEMI because technically speaking, if you walk in or brought in by EMS, you're really not admitted until a diagnosis is made, and then, usually you're on your way to the cath lab. And I think we're all familiar with what happens if you don't get all that admit paperwork and get you logged in the system. If you're arrived in the cath lab, it's all your record keeping really gets messed up. So a pre-admit STEMI is anybody that has their event before the time they are actually officially admitted to a hospital. It goes over what are the exclusions here. If you're transferred from an outside facility, that means that you're actually in the other metric we're going to talk about. Or if you received lytics, then you really, even if you still go to the cath lab, you're not a primary PCI, you're a rescue PCI. Then there's always exceptions, and I think you're familiar with these. We won't go over these. There's the patient-centered reasons. There's the non-system reasons if you're enrolled in a clinical trial. And then the new one that we've already described is right here. Now, reading through this, you might have a little bit of time or trouble understanding exactly how to put this in context. So I've made this timeline here for you. And this is a typical timeline. EMS arrives, they do what they always do with great expertise, assess, stabilize, and then pack up the patient for transport. They leave the scene, they transport the patient, they arrive at the door of the PCI facility, and then sometime after that, the first device is actually activated. And what the change in the metric says is if this time, from the time EMS arrives or the STEMI diagnosis is first made, is more than 45 minutes or more, and, important and, this total time is more than 90 minutes, they are eliminated or they're dropped from the denominator. The reason that this last one is in here is actually if the total time is less than 90 minutes, you have made the metric. In other words, you get credit for getting a very good time. So you don't want to drop people that have a time of less than or equal to 90 minutes here. Now, just looking at our own experience, which we try to keep track of a lot. I mean, we're, of course, located here in Roanoke County, but we look at the surrounding counties here in this bluish color, our expanded counties in the reddish color, and we can get patients from 3 counties, primarily in West Virginia, Pocahontas, Greenbrier, and Mercer County. That's a pretty big area. I'm not saying that all these patients automatically come to us, but we do get patients from all these areas. So the transport time can be a big issue for us. And I'm actually going to share a bit of our experience with this. Before the exclusion, you see the sad face there because our results before this exclusion kicked in, they weren't very good. And what happened is after this exclusion, we had 33 of about 130 patients, but 33 were eliminated from the denominator. And with that, you can see that our results got much better. We're above the 50th percentile here in this kind of, green zone where I think we all desire to be. So this has made a big difference for us. So it is a very important change. There is, you remember this guy, this is Billy Mays, the old OxyClean guy. Well, there's another change that's coming that you really don't know about yet. I think many of you on this call probably know Connie Anderson. I've worked with Connie for years, mainly on the appropriate use criteria. But I actually was writing to Connie over something else. This is a comment, or this is a copy of our email. And I said, gee, these changes are really great because they really make us look a lot better. And she brought up the fact that they're changing it again. And that's something you have not seen yet. And what they're doing is they're changing this first medical contact to EMS leaving the scene, which they feel will more accurately capture the EMS transport time or their driving time. And they can't make changes in the cath PCI registry. We'll talk more about that later. So I was worried because I hadn't seen this happen yet. So I wrote back to her about a week or so ago because I want to make sure that I was going to give you a good information, not bad information, and she confirmed for me that yes, that change is going to happen. Probably sometime later on this month, you'll see an announcement about this change happening. So what does the new change look like? Again, using our same kind of timeline here, it was from when EMS arrived, but I think we all know from talking to our EMS colleagues that sometimes it can take them quite a while to assess and to stabilize the patient, especially if they're critically ill, and then to get them ready for transport. So what the new time metric that you're going to see in a couple of weeks here actually starts the clock when the patient or when EMS leaves the scene. And if it takes them greater than or equal to 45 minutes from the time they leave the scene to get to your hospital, then, and this time winds up being greater than 90 minutes, they're excluded from the denominator. And I haven't seen results for our own program here at Carilion, but I know that we deal a lot with what we kind of have nicknamed twofers, and that is the patient will get picked up by EMS, oftentimes in very rural areas, and then EMS transports them to a local football field or church parking lot or something like that, where they do a transfer to helicopter service to bring them the rest of the way, just because the distance is so long. So I'll be anxious to see how our results look when this new revision to metric 37 kicks in. Moving on now to the other metric, that's 56. This is the time to primary PCI among transferred patients. Again, it's the same kind of format which you can get from this document I highlighted earlier. I won't go through this in great detail, but the metric here, because I think you're all familiar with it, is the goal is less than 120 minutes if they're transferred in from a non-PCI capable facility. Again, trying to put that into a timeline, it looks something like this. EMS arrives, they stabilize, assess the patient, stabilize. They leave, they arrive at a non-PCI facility, and the patient is usually evaluated there, and the time is greater than or equal to 45 minutes from the time of departure at the non-PCI facility until they actually get to your facility. So that's going to be the change. And there's actually an interesting study that was published that is very close to looking at this metric number 56. And that study was published in July of this year. It actually comes out of Mission Lifeline STEMI Accelerator project, and it was run out of Duke. And the hypothesis here is a faster activation at the referring hospital associated with improved perfusion times. And they looked at about 2,000 patients from this, and they divided them into two groups. If the activation, and they define this somewhat arbitrarily, takes place in less than 20 minutes or more than 20 minutes, which they called delayed. And they too created a couple of nice timelines here. When it took more than 20 minutes for the referring hospital to connect and activate the cath lab at the receiving hospital, and that was about 1,200 patients, you can see that their total time was up here close to 130 minutes. If they activated the cath lab very promptly, less than or equal to 20 minutes, you can see that their total time to device activation was more in that 90 to 100 minutes. So clearly a much better result. So the message here to all the referring hospitals is please try to assess the patient as quickly as you can. And then once you've made an assessment that the patient is having a STEMI, that you contact your referring or your receiving hospital as soon as you can, because that really sets the ball in motion to get things rolling as far as their transport is concerned. You can see in these two scenarios here, transport times were just about equal, And from the time they got to the second door, that's the PCI hospital, until the device was activated, was just about the same. So the biggest difference is in this door in, door out time, 68 versus 40 minutes. So this study again highlights the importance of that very early call to activate the cath lab at the receiving hospital. And their conclusions, as summarized below, were that cath lab activation within 20 minutes across this diverse group of hospitals in the STEMI Accelerator program was associated with better performance in achieving the goal of less than 120 minutes in more than 3/4 of the patients. So again, a very important opportunity to bring about improvements in this metric number 56. So one of the questions I asked Connie Anderson, knowing what's in some of the other registries, was, well, how about making those changes in the cath PCI registry? Because there are two metrics, and they're listed here, PCI within 90 minutes, and then the median time to PCI for transfer patients. I said, why don't you make the same changes in that registry? Because, otherwise we're going to have kind of different times. And her answer was kind of, well, I wish I could, but we can't. And the reason they can't is because the data fields in the chest pain MI registry are more extensive, and they collect things, a lot of which are highlighted here in yellow, such as when EMS leaves the scene, when the activation is done, when they arrive at the outside facility. And none of those fields are in the cath PCI registry. You would think it would be wonderful, because they're probably the same patients. If the patient is in cath PCIs having a STEMI, they're probably also, if the hospital participates, going to be in the chest pain MI registry. You would think that the registries could talk to each other, but unfortunately they can't. So these changes will not automatically migrate to the cath PCI registry. I think at that point I will stop. I think Peter wants to hold questions to the end. So I'll just stop at that point, and thanks for listening.
Thank you, Dr. Dehmer. That was wonderful. And yes, we will hold questions to the end. So we will go ahead and move on to our next speaker. I want to introduce Dr. Alex Truesdell from Virginia Heart. He is also affiliated with Inova Heart and Vascular, and he is going to talk about a clinical issue that I faced on call this weekend, a big dilemma. I'm sure many of you have as well, when to take or if to take a post-arrest patient to the cardiac cath lab. So Dr. Truesdell, thank you, and we're eager to hear what you have to say.
Great, thank you very much for having me. So obviously a very hot topic that's everybody faces on a regular basis, and they think there's a lot of controversy and frankly a lot of unknowns. And I may not leave you with a lot of knowns, but I'd be happy to hear people's thoughts about things afterwards. Next slide, please. Here are my disclosures. Next slide, please. So just to sort of set the stage, from the most recent statistics, there's nearly 400,000 out-of-hospital cardiac arrests annually in the United States. I got 2 phone calls yesterday. Sounds like you've got a phone call. These things, are very, very common. And I think one of the things that we have to think about in breaking them down is acute coronary syndrome versus non-ACS, ST elevation MI versus non-ST elevation MI. Although I will add the caveat there's things in between that, other people may have heard the nomenclature of, occlusion myocardial infarction, and something that is a STEMI, but STEMI variants, so to speak. And I think we have to take the clinical history into account a lot and really scrutinize the EKG when we're deciding if something is a STEMI or NSTEMI, because it's not always entirely clear. Is there a shockable versus non-shockable rhythm in arrest? And sometimes, that is a first, second, or third hand story, and there may be a lot of unknowns. And then the decision, do they go to the cath lab? And for facilities that have the technology or near to other facilities, do we talk about ECMO? And then a little bit on future directions. Next slide, please. So luckily, there's been a lot of documents coming out the last couple of years. So I think most of my references that I'm going to go over here in the next 10 minutes are all from the last 3 years, and many of them in the last 18 months. So this was a nice AHA scientific statement talking about the role of the cath lab, specifically in management of patients with out-of-hospital arrest. And again, talked about the delineation of patients with an ST segment elevation, either on the pre-arrest or post-resuscitation EKG, and that the majority of these people have a very high rate of coronary artery disease in the 70 to 85% range. Patients likewise that have ventricular fibrillation or pulseless VHAC arrest, even without ST elevation, still have a significant finding of coronary artery disease. In some studies, 25%, but really upwards of 50% in many studies. Next slide. I think also when you look at this data, there's a couple. Sorry. Click back. I think the words went away. You just click back and click back onto it. Okay. So again, when I talked about whether you have VF and pulseless VTAC, do you have ROSC, or do you have refractory arrhythmias, is really going to impact survival. And then I think there's the other piece about what about non-shockable rhythms. I think the impact of coronary artery disease in these is unknown, but in general outcomes are poor. And these are largely, I think, patients that in the absence of a really good clinical history, without a shockable rhythm, without ST elevations, that most of us would not take to the cath lab. And that's probably been validated by most of the literature and also some trials later. And the other thing is, we're not just talking about resuscitation in the cath lab, but also want to talk about who is going to survive, but who is going to survive with favorable neurologic outcome. And usually we look at the cerebral performance category, CPC 1 or 2, which would be people that are able to maintain jobs, perform activities of daily living, and live on their own. Next slide. So this is a great article, and actually, as I put it up here, I couldn't believe it was from 2015, because I guess I thought it was more recent. But the cardiac arrest hospital prognosis. And the reason why this article is a must read, I think, for everyone, is it has a very nice, simple tool for risk stratification for patients in out-of-hospital cardiac arrest. And this is a nice tool to decide in the middle of the night, is this somebody that should go to the cath lab now, or perhaps not. Next slide. And so some of the variables to decide on should someone go to the cath lab that were demonstrated in this study to impact survival were age. I think not surprising. The setting of arrest, was it witnessed? Was it unwitnessed? Was there bystander CPR or not? What was the total time of collapse until initiation of resuscitation? What was the total duration of resuscitation? Were the rhythms shockable or non-shockable? How many doses of epinephrine? What was the metabolic profile? And they used a pH and creatinine. So I think a lot of these things intuitively would make sense to us, and this was sort of validated in their analysis to be to assist with prognostication and outcomes. Next slide, please. And so ultimately they came up with this scale that looks at these 7 admission parameters: age, cardiac arrest setting, home or in public, really again getting in that witnessed or unwitnessed, shockable rhythm, yes or no, what was the time from collapse to initiation of BLS, what was the total duration of BLS, what was the presenting pH, epinephrine doses. And then in each of those scales, you'll come and get a point total. And again, I won't go into it in detail, but if you look at the article, it gives you kind of a rough summary. And then, when you have a total point scale, somewhere around the 170, 180 range, you're looking at an 85 to 90% mortality. And it's looking at, this is looking at the survival, the chance of survival with a favorable neurologic outcome. And so this is helpful not only when you're evaluating patients, I think, but to have a common language to discuss with the ER folks. And ideally, you would want consistent answers so that a patient gets the same care regardless of what interventionalist or ER physician is on the, or intensivist is on the phone, and whether it's Monday, Tuesday, AM or PM. And so we've, utilized this and discussed this, locally, again, to try and standardize approaches as much as possible. Next slide, please. So here's another article from 2017, which again is just looking at what is the prevalence of coronary artery disease in patients with refractory ventricular fibrillation, cardiac arrest, and advocating that a systems approach to reperfusion, and in this case specifically ECLS, or as most people would be more commonly known as ECMO. Next slide. Here is the central figure. I think a couple things to note, and I'll touch on this a little bit later in the talk, is really what they analyzed is they looked at a historical control of patients that had refractory VF, out of hospital arrest, so ongoing refractory arrest, refractory and ongoing resuscitation, and obviously people that obtained ROST and were admitted to the hospital. What was their survival? And you see historically a survival rate of 15%. And so the University of Minnesota in their Minneapolis-St. Paul area evaluated a program where people would be early transport to the cath lab for ECMO, angiography, and PCI in the cath lab, and then analyze what was their survival. And we're able to improve survival to 45%. I will say this was an amazingly heavy lift and a real coordinated effort, if you think about this, to achieve this. And I'll make 2 points. So look at the success they've been able to have. And yet the counterpoint is still 55% death and a lot of resources. And this is not something you can do without a real targeted, concerted, collaborative effort. And you have to have a lot of buy-in institutionally and from the community. Next slide. And I'll touch on this a little bit later. So here's another article just from 2020. So this is outcome predictors of patients with out-of-hospital cardiac arrest and immediate coronary angiography, following in the same theme. So patients without return of spontaneous circulation that had coronary angiography with ongoing CPR by automated Lucas device, 56 patients, 55 died in the hospital, okay? So again, we talked about, we have NSTEMI, STEMI, ACS, non-ACS, shockable rhythm, non-shockable rhythm, ongoing arrest versus not. So the previous slide I showed you was a study where these people went to ECMO, ECLS, eCPR. If you don't have that technology available, for patients with ongoing refractory arrest, taking them, ongoing CPR, pretty poor outcomes. People that had ROSC at some point and had ROSC at admission to the cath lab, you can see much more favorable outcomes. Still, less than 50%, but a far cry from the near 100% death rate. So this is an interesting article from a group out of Germany. Next slide. So, and again, what their conclusions are is that, again, if somebody has a non-shockable rhythm, and that you're unable to achieve return of spontaneous circulation, people with ongoing CPR mortality is very high, and perhaps this may not be, a patient population to take to the cath lab. And when you look at some predictors of mortality, again, age, not surprising, whether this was a shockable or non-shockable rhythm, again, whether they arrived to the cath lab, necessitating ongoing CPR or not, and their initial pH. Next slide. So here's, a lot of people are familiar with the COACT trial. I think this got a lot of press, a lot of discussion. This was a 2017 paper that looked at coronary angiography after cardiac arrest without ST segment elevation. So these are patients that had a shockable rhythm, but no signs of ST elevation, myocardial infarction. And they determined that there was no benefit for immediate angiography, and that in these patients, you could admit them to the intensive care unit, assess their neurologic outcome, again, as long as they're not in shock, they're hemodynamically stable, and there's no ST elevations, no ongoing, refractory VT or VF, and that the outcomes would not be different compared to patients who went immediately to the cath lab without knowing their neurologic status at time of entry into the cath lab. Next slide. So you could see when they looked at survival at 90 days, delayed coronary angiography and immediate coronary angiography were essentially similar. And again, this was patients out of hospital cardiac arrest, initial shockable rhythm, no ST elevations, and unconscious after return of spontaneous circulation, 1-to-1 randomization to immediate coronary angiography or delayed coronary angiography, which typically happened not only after neurologic recovery, but if you drill down, was typically once they were out of the intensive care unit. Next slide. So that previous study, I think, has influenced us locally and a lot of people for criteria of saying, well, it's safe in that population that I just described to put them in the ICU and then reassess. Here's a paper from this year, again, looking at patients' non-shockable rhythm without ST segment elevation, and that showed that most likely routine angiography on admission is likely not clinically beneficial. Next slide. So you can see non-shockable rhythm, no acute coronary syndrome. You have a very poor survival in this group. So a lot of common themes that are recurring from papers, published in both the United States and in multiple European countries now. Next slide. So just over this summer, the Society for Coronary Angiography and Intervention published an expert consensus statement on out-of-hospital arrest. And again, what their best practices summary highlights what sort of already said. So out-of-hospital arrest with non-shockable rhythms, recommend deferring transport to the cardiac cath lab. Out-of-hospital arrest with shockable rhythm and a STEMI on the post-ROSC EKG. Recommend a definite invasive strategy, again, absent any other contraindications. Patient with a shockable rhythm without STEMI, you can defer the invasive strategy in hemodynamically stable, so non-shock patients, and to allow time to assess their neurologic status. Next slide. And again, when they talk about the risk scores, highlighting here the cardiac arrest hospital prognosis score that I mentioned previously, and again, highlighting that throughout multiple trials, what seems to stand out factors associated with not just survival, but survival with good neurologic outcome is age, whether arrest was witnessed or not, was there immediate bystander CPR or not, was ROSC achieved quickly or not, was the rhythm shockable, and then what their overall metabolic profile via lactate or pH. Next slide. There's some other trials going on in the future. I think the ACCESS trial is going to be interesting once the results are available. And this next slide, again, I just refer you to this document. This reiterates things we already said about how you approach a patient that is awake with return of spontaneous circulation. Go to the cath lab, return of spontaneous circulation but comatose, have an emergent evaluation, and then do a neurologic assessment and assessment of some of the other features to decide if they're STEMI, non-STEMI, shock, not shock, and whether they have favorable or unfavorable features, whether they should go to the cath lab or not. And then this category of people with ongoing CPR, would they be appropriate for ECLS or ECMO? Next slide. And again, this is just laying out what I just said. Next slide. And this actually just came out about a week ago. And this is going back to where I mentioned in Minnesota. So they have a really dedicated program, and this looked at 5 months. You had 63 consecutive patients with refractory ventricular arrhythmias with cardiac arrest. You can see the mean age, and they had a 43% survival of patients that were discharged alive at 90 days with cerebral performance categories 1 and 2. Next slide. Very resource intensive programs. So this was in the Twin Cities, Minneapolis and St. Paul, 24/7 services. They actually have interventional cardiologists driving around in an EMS vehicle. You had mobile ECMO teams, 3 ECMO initiation centers, which then centrally transported patients throughout the Twin City area, the whole metro area, to one centralized ECMO intensive care unit. Next slide. And again, had favorable timing of activation and provision of therapy. But you can see a snapshot, long hospital stays. A lot of patients went to acute rehab. Next slide. But again, overall achieving that 43% survival. And pretty clear exclusion criteria, excluding nursing home residents, DNR, bleeding, terminal illness. Patients were also declined for ECMO if they had lactate over 18, PaO2 less than 50, or end-tidal CO2 less than 10. And patients all had a pan CT scan, head, chest, abdomen, pelvis, entry into the ER, followed by the cath lab before going to the ICU. So real labor intensive, resource intensive program, but shows what's possible. But whether this is able to be replicated in other jurisdictions remains to be seen. Next slide. I'm going to skip over this case in the interest of time to just keep going, slide, in the interest of time, just so we can get to a discussion. Keep going. Just, keep going. Next slide. I will highlight that in our cardiology team activation protocol, we do have the CAHP score listed. Next slide. This is some of the shock team stuff that I think you'll get in the next slide. Next slide. In the next talk by Dr. Tarani at the next section. Next slide. 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 So that case, just I'll tell you in short, was a gentleman who came in with a cardiac arrest, 90 minutes of CPR, was put on ECMO in the cath lab, had a triple vessel CTO, ended up fixing one of the CTOs as an inpatient, another as an outpatient. He now cycles 10, 20 miles a day, but had a 30-day hospitalization, and really shows what may or may not be possible in different institutions. Again, not everybody's going to have ECMO after 90 minutes of high quality CPR and then have all the other things available. So in conclusion, I think non-comatose patients, it's your usual care. You have to have prognostic scores for comatose. I personally think that CAHP score is a very helpful score. Cardiac arrest with ST elevations, shockable rhythm, return of spontaneous circulation in comatose should go to the cath lab. I would submit, by the way, to the evidence. People with non-STEMI that are out of hospital rest with a shockable rhythm that have return of spontaneous circulation and are comatose, we can safely defer based on the COAC trial. Out of hospital rest with no ST elevations, non-shockable rhythm, also defer. That some select centers and jurisdictions may want to further evaluate the utility of ECLS or ECPR. And I think that there's important to have local team consensus and consistency. And I think it's very important for all of our patients that everybody gets the same care Monday, Tuesday, AM, PM. And I think that's one thing that we should all strive for, that regardless of where our neighbors buy a home, that they should have the expectation of similar standards of care, whatever, however we decide that may be. Next slide. And that's it. Thank you very much.
Dr. Truesdell, thank you so much. That was fantastic. I liked your last statement because that's really the mission statement of VHAC, which is, where you live should not be a big determinant of your outcomes. And that, I think, is the central argument for regionalized systems of care. You should do just as well with shock, cardiac arrest, STEMI in any corner of the state. So thank you. Fantastic review of the literature. This is something, like I said, I just faced this dilemma over the weekend. We're going to open it up for questions for both Dr. Dehmer and Dr. Truesdell in a moment. But Dr. Truesdell, if I can start with the first question, I think I'm kind of getting a picture of what to do with this patient, but I want to get kind of your feeling on this. I think the folks in Minnesota may have addressed this, but you get a patient with refractory VF, no ROS, comes in a Lucas device, ECMO cath lab, all of the things being equal. I know we could say, how long they were down and their age and some of the things that go into the various scores, but I think we clearly know the populations, got ROS, STEMI, reasonable candidate, go to the cath lab. Everybody else, it gets a lot murkier or there's no benefit. But what would you do with that patient? Because we had that patient not long ago.
Yeah, it's a great question and it's super, super tough. To me, what breaks out in a lot of these trials is age is a big determinant. And when I say age, it's not a value judgment. It's, a 35-year-old, I can beat that person to a bloody pulp for 30 days and they can walk away. I can't beat a 90-year-old, what they have to go through, multi-organ failure and through a hospitalization, and have them walk out intact on the back end. And everybody's in between. One of the values, I think, of our shock program is that phone call is not just the interventional cardiologist anymore. It's the heart failure specialist, it's the cardiac surgeon, it's the intensivist. And I think that is key in having standardized decision-making, a consensus plan of care, and other questions. Once somebody's asking about candidacy for VAD and transplant, they're thinking that way. Someone else is thinking about contraindications, perhaps to, ECMO. Are there other circulatory support devices, cath lab or not? And in just a few minutes, by putting those minds together from the different specialties where we have that Venn diagram of our different overlapping expertise, to me, I think that's the most critical component. I think it's also critical for those people that we decide not to take. We do it for an objective reason. Emotion is taken out of it, and we feel like we've made that decision together. And for patients, sometimes when we're talking to an outside facility and it's a transfer patient or the ER, that you're not leaving the ER physician or the transferring physician to feel like they're responsible for making a life and death decision. We're doing it based on consensus with our best available evidence, and we're doing it together. So, that it's not sort of left on somebody's conscience, which I think is a big issue that we underestimate and don't always talk about when we're going through it. So age, the discriminators in that score are great. Witnessed, unwitnessed, time of arrest, age, comorbidities, what exit strategies. Sometimes there's a lot of unknowns. And for the ECMO piece, what we also have decided as a facility and a group, just because you put someone on ECMO doesn't mean they go on. And so we'll talk to the family. If we make that leap of faith, that doesn't mean we may not reassess at 24 hours, and we will. And I think you have to think that way too. And it makes us more likely to put people on if we know that it's an initial step. But I think we're all learning together.
Fantastic. I'll open it up for other questions.
Hey, I just wanted to say, this is Rahul Sharma. I just wanted to say thank you to Dr. Dehmer and Dr. Truesdell for two great presentations. I just wanted to kind of highlight a couple of things as a comment, really more than a question, and this is to Dr. Truesdell's presentation. I think your point, Alex, about kind of bringing more stakeholders to the table when it comes to having an actual shock team approach, where you get the heart failure cardiologist involved, the interventionalist, the physician in the ER that's caring for the patient, the cardiac surgeon, so forth. I think that's really crucial to making the program successful, because when you get into a binary scenario, the ER physician versus the cath lab interventionalist, I think that's just not a great interaction, and it sort of puts more emotion into the equation rather than objectifying it. The second point I wanted to make is that I think that there's a real discussion to be had about the strain that having a shock protocol or system of care within a hospital that could be placed on the cardiac surgeons, the cardiac surgery ICU, because at most hospitals the ECMO program is ran by the cardiac surgeons, and depending on how many ECMO machines you have and staffing and other patients who are having cardiac surgery that might need to come out of the OR on ECMO and so forth, obviously there needs to be a major institutional discussion that would need to be had about what are the resources and utilization issues at your particular institution? How are you going to run X number of ECMO, units or machines at any given time? How's that going to impact availability for patients undergoing cardiac surgery for other issues and so forth? So it's just such a massive dynamic discussion. But certainly, I think your presentation, is fantastic and really highlights the ways in which all of us within the Commonwealth need to think about this for those of us who work at systems that are really interested in implementing something like this. It goes way beyond an interventionalist who's interested or an ER physician, who's interested. It has to involve so many other stakeholders. But thank you to both of you for two great talks.
Excellent. Thank you, Dr. Sharma. Yeah, we like to say STEMI is a team sport, and I think post-arrest care, cardiogenic shock is absolutely as well. We probably have time for one or two questions. There was a question about availability of slides. This will be on our website. We'll have a recording YouTube video on the website in the very near future. So we'll make that material available for everybody. Let's see, what else do we have for Dr. Dehmer and Dr. Truesdell?
I have a question for Dr. Dehmer, if I may. This is Evan Ownby. That was both great presentations, but I had a question about the metrics. This has the potential of significantly impacting the metrics and the outcomes that we measure, the two metrics that you changed. And I wonder if this is comparable to perhaps baseball. Every situation deserves a good baseball analogy. But is this going to be the pre and post steroid era when we change these metrics? Because it significantly changes the denominator. And when we compare things pre and post 2020, we, in a sense, are comparing apples to oranges. I wonder what your take on that is.
Well, it's a great question. I wish I had a good answer for you, but unfortunately I don't. So much has changed in the since March of this year when we're all dealing with COVID-19 that I really don't know how it's going to look in the future. I think like most hospitals, we have seen a slight decrease in acute STEMI care. That certainly has been published by others. And, how these metrics are going to change in the future, I would just say that, your guess is as good as mine.
Fair enough.
I think we can take one more question. Okay, if we have no other questions, I want to thank Dr. Truesdell, Dr. Dehmer, Amanda Pyle for helping us put together this great presentation today. Again, stay tuned. We're shooting for the first quarter of 2021 to have our next virtual state meeting, which will most likely center around shock. So that should be a great event. Thank you, everybody. And as I mentioned before, these slides, this material will be available. Please check out the website in the coming weeks. And also, let us know what you thought. What else could we do? What other presentations or topics may be of interest or clinical relevance? We're certainly all ears. And would encourage you, again, to get active in these regional systems of care for arrest, shock, for STEMI, and all the rest. Again, these are team sports and we need everybody on board. So again, thanks so much to our speakers. This was phenomenal and really look forward to the next one. Thank you.
You're welcome.